Ahmed Kamel for his talk about radiation segmentectomy for HCC as curative treatment. Do you have enough evidence, Professor Dr. Ahmed?
Thank you so much. Try to be on time this time. So the background is that we can deliver Y90 or radioembolization at a bilobar level, lobar level, segmental level, or even very close to the tumor. So the idea of radiation segmentectomy started, very long time ago, like in 2011, by the publication from Riyadh, from Northwestern, where, as you can see here in this example, this is a tumor in the left side, left lobe of the liver. They go very, very distal with their microcatheter, very close to the tumor, and inject a very high dose of Y90, close to like 500 grays, to the treatment area, and they wipe off, completely destroy this part of the liver. That includes the tumor as well. As you can see, this is the segment of the liver that dies afterwards. And as you can see here, they used a very, very high dose to that treatment segment, close to like 521. That's the mean dose that they used. They found that there is really no RILD, which is the radioembolization-induced liver disease. 5% only of the patients had small biomas, 1% had biliary strictures, so very, very low side effects. This is a case that we did in our institution, just another example. There's a very small tumor, around 3 centimeters in the segment 7, almost like 1.3, I guess, meets the criteria for HCC. This is the replaced right hepatic artery. We went very far with our microcatheter, very close to the tumor, and then did a cone beam CT here. This is the segment that will die later. That includes the tumor in the middle of it. This is after injection of Y90, giving 520 milligrays of Y90 or of radiation to the treatment area. And this is the follow-up. As you can see, the whole tumor, as well as the surrounding liver tissue, is now completely necrotic. And the assessment here by MRECIST would be complete response. But not just this. This is after 1 month. When you look at 3 months, that segment has decreased in size. And after 6 months, even smaller. That's why we call this radiation segmentectomy, because that segment or that area of the liver, after some time, is going to fibrose and disappear, as if you did it surgically. Then Vouch decided to see if this is really an ablative technique. So he did a radiologic pathologic correlation. He looked at 102 patients with solitary HCC less than 5 centimeters that had a very high dose, again, 242. This is more than what the companies or the package inserts actually advise you to do, which is around 120 grays. This is like almost double that. So he looked at this, and 33 of these 102 patients did liver transplant. So he looked at the pathologic correlation of this with the radiologic appearance also. He found that 90 to 100% of these had tumor necrosis. And he found that if you give a dose of more than 190, you are more likely to get complete pathologic necrosis than if you gave a dose of less than 190. As you can see here, they don't really get that. So he advertised again for using a really high dose, more than 190, in order to get complete pathologic necrosis. We do Y90 generally now for these indications on the BCLC, which is very early stage and early stage. When these modalities fail, this is the curative segment where you can do either ablation, resection, or transplant, and they have a very, very good survival advantage. However, if you cannot do any of these, then you can do either TACE or Y90. Y90 is indicated up to 8 centimeter lesions. Also, if you do Y90 and you downstage these lesions, you can go back and transplant these patients as well. Technique is very, very important. However, in my own opinion, you have to have cone beam CT to be able to do radiation segmentectomy. You're going to give a very high dose of Y90. You have to be really sure that you are covering the tumor and the surrounding area, especially when you have tumors in the watershed areas, which are segments 6-1, 8-4A, 4A and 2, 2 and 3. We'll see some examples here. This is an example of a tumor that is between the caudate, which is segment 1, and 6. When you do the cone beam CT, here is this is the caudate artery, and you can see it's giving the tumor. And when you go to the segment 6 artery, it's also giving the tumor. So you have to give a dose in both of these arteries. Otherwise, you will not kill all the tumor. That's an advantage of doing cone beam CT. Here's the follow-up after 1 month. The tumor is completely necrotic here, and it completely disappeared at 42 months, no recurrence. Obtaining cone beam CT is also very, very important in order to accurately calculate the volumes, which is related to the dosimetry. You're going to decide how much you're going to give to that patient based on the volume of that area that you are going to treat. And you cannot get accurately the volume unless you have cone beam CT. So this is just an example of a tumor in segment 8. You can go very, very peripheral with your catheter. Here's the tumor. And then when you do the cone beam CT, here's the tumor. And that's the area that will completely be necrotic. So you can use that to calculate the volume. Here, the volume of the tumor is 14 mLs, while the volume of the treated area will be 63. Based on this, you can plug these numbers into the equation and get the accurate dose that you have to give to that patient. Here's the dose of 190 given targeting this area that has the tumor in it. We use the MERD model because this is, again, a segmentectomy. Don't try to waste your time trying to do BSA or partition. Just use 500 or more than 400, whatever, more than 400 is better, more than 400 grays to that treatment area using the MERD model. Whenever you have or you cannot separate a very small segment, you can use innovative techniques to try to minimize non-target embolization, non-target treatment or 190 treatment. So you can use coils or gel foam, or you can use flow-modifying microcatheters. We're going to look at an example of this. This is a tumor here, very close to the heart, so ablation was not an option due to the proximity to the heart. Again, it's in segment 2-3. So when we did the angiogram, mapping angiogram, you can see there's 2 arteries. There's this one and there's that one. I thought it was this artery that is feeding the tumor that you can see here. So I went into this one, and indeed is feeding the tumor. But when I did the cone beam CT, there's part of the tumor here that is not opacified here by the contrast, which means it is not really fed by this artery. So I went to the other artery, and indeed I found this branch here from the other lower artery, which supplies segment 3. And it's giving that tumor by cone beam CT, is giving that missing part. And when you put them together, you can fuse these 2 cone beam CT together to make sure that you're covering the whole tumor. And then we did the MAA study, and you can see part of it is going to this, segments of the liver, simply because when you look at the angiogram here, there's this artery that is giving the tumor, but there's a lot of arteries here that are giving the rest of the left lobe. So in order to minimize that, you can, on the day of the Y90, you can embolize by gel foam these distal branches. As you can see here, these are blocked now. And so when you inject the Y90, it all goes into the tumor. You do that also for the other branch, which is segment 3 branch. You embolize those. As you can see here, it's embolized by gel foam. These will open up again after a week or 10 days. And then you inject Y90, so it all goes into the tumor. And here is the, again, the mapping study. The post-190 study. When you compare it with the mapping, you see mapping extends way to here. This one is more targeted and more focused here. And this is the follow-up. As you can see, it actually affected just that tumor here and maybe a little segment here, but the rest of the liver here is still preserved. And again, after 6 months, no recurrence. It's all dead area if you use, again, high dose of Y90. Outcomes, this is the legacy study, a retrospective study for 162 patients for unresectable lesions that are less than 8 centimeters. Again, the objective response rate was pretty high, 88%. Most of it was complete response or partial response. There was no stable disease or progressive disease in that study. All of them were either complete response, which was the majority. The green is complete response, which means you don't have any tumor left. Partial response means the small part of the tumor is still present. And when you look at the duration of response, which is the time frame from having a response, either complete or partial response, until progressive disease happens, until the tumor progresses again, it's almost 15 months. This is pretty high. This is very comparable to curative treatments. So when you look also at median progression-free survival is 57 months. You cannot compare that to TACE. This is compared to ablation, to transplant, to resection. This number is basically compared to curative treatments. When you look at also the overall survival of these patients at 3 years, 86%, they are still alive. In terms of serious side effects, those who had grade 3 or more side effects were 19%, almost like 20%. 10% of them were serious, but only 5.6% of these were related to the radioembolization. There was several deaths, but not related to the treatment. So it produces a clinically meaningful response rates and prolonged duration of response. And the overall survival and progression-free survival are very, very comparable to curative therapies. This is another study which is very, very, very intuitive in the sense that they compared a pathologic correlation again with the radiologic correlation. So they found out that if you have a dose of more than 400, again by pathology here, you will get complete tumor necrosis, versus if you have less than 400 dose to the treated area, then you might have a mix of them. Some of them will have complete pathologic necrosis, some of them will not. Another study from Mount Sinai by Ed Kim, prospective for 29 patients. Again, smaller study compared to the legacy. Again, smaller size, but again, similar criteria for the patients. They gave an average of 580, so not 400 like the other study advocated, but this is 580 grays to the tumor. Again, objective response rate was 100%. The sustained complete response, which is the duration of response, was 90%. So very similar numbers to the legacy, which again proves that this could be considered as a curative treatment. Again, the overall survival at 2 years was 96%, very, very high number. Again, when they looked at 8 patients who underwent liver transplant, they found 100% tumor necrosis. All these patients that had 580 grays actually had complete tumor necrosis. So these are more, studies that have been done also comparing radiation segmentectomy with TACE plus microwave. TACE plus microwave is done as a curative treatment again. So the results were very, very comparative. As you can see, the p-values are not significant for both the complete response, for time to progression and overall survival. So that's why, this radioembolization now is here in the BCLC algorithm for patients who are not eligible for these curative treatments. So in conclusion, do we have enough evidence? Yes, we do have enough evidence. Radiation segmentectomy offers comparable outcomes to curative treatments, including resection, transplantation, and ablation. However, you have to do a selective treatment, and you have to give a dose of more than 400 gray in order to achieve this. So does the dose matter? Yes, dose matters, and it actually matters a lot. And with that, I'm going to conclude this. Thank you so much.
Many thanks, Dr. Ahmed, for this nice presentation. Next, Dr. Praveen again.